Hello and welcome to Our American States, a podcast from the National Conference of State Legislatures. I'm your host, Ed Smith.
There is a well-documented evidence showing that poor oral health does not only have effects on your overall health, but it can play a determinative role of whether someone can be gainfully employed.
That was Ian Hedges, the Director of Medicaid and Medicare Program Policy for the American Dental Association. Hedges is one of my guests on this episode, looking at oral health care coverage under the Medicaid program. He's joined by Senator Evan Vickers, a Republican of Utah, and Senator Malcolm Augustine, a Democrat from Maryland. Oral health care for children is required in every state under Medicaid or the Children's Health Insurance Plan, but dental coverage for adults is optional. And while nearly every state provides some level of coverage for adults, what's covered and who's covered varies widely from state to state, and even within states. Hedges explained how oral health care affects overall health and why different levels of coverage for adults can lead to higher costs later on for health complications that arise from neglected oral health issues. One study found that untreated oral health conditions can lead to health complications that cost the U.S. about $45 billion each year in lost productivity. Senator Vickers and Augustine explained how their states have approached broadening coverage for adults, the challenge in assembling a group of providers who will accept Medicaid reimbursement, and some of the particular problems in providing care to those with low incomes and those living in rural areas. Here's our discussion, starting with Ian Hedges. Ian, welcome to the podcast.
Thank you so much, Ed, for having me.
So, Ian, just to get started, I wonder if you could tell listeners a little bit about your role at the American Dental Association.
Yes, so I'm the Director of Medicaid and Medicare Program Policy at the American Dental Association. So I work on educating our members and other dentists about becoming dental providers for patients that utilize public benefits. I also work with our state association and federal advocacy team to ensure these programs meet the oral health needs of the patients we serve without putting undue burden on the providers. And finally, I work very closely with the ADA's Health Policy Institute on research around Medicaid and access to care for vulnerable populations.
Ian, as you probably know, our audience is largely state lawmakers, state legislative staff, others interested in state policy. With that in mind, could you talk a little bit about how oral health contributes to overall health and why it's a policy area legislators should care about?
We know that there are systemic connections to overall health when oral health is not addressed. There is research that suggests heart disease, clogged arteries, and stroke might be linked to the inflammation infection that oral germs can cause. Many people also do not realize this, but periodontitis, or what we know as gum disease among pregnant women, has been linked to premature birth and low birth weight. So there is a well-documented evidence showing that poor oral health does not only have effects on your overall health, but it can play a determinative role of whether someone can be gainfully employed. And I not only come from this as a policy wonk, but as someone who formerly operated a community health center with safety net medical, dental, and behavioral health clinics. And constantly, we had patients with diabetes who were being treated at our medical clinic. And the doctors would say, well, frankly, you need new teeth because even if you had programs to help with food insecurity or received incentives for purchasing healthier foods, it is not going to help your diabetes if you do not have enough healthy teeth to chew fruits or vegetables. And we also know that patients with substance use conditions and when someone is going down the pathway of recovery, you need a new beginning or a second chance. And how is someone going to be able to get that when your smile does not bring you the confidence to improve your life or help you get a job that improves your situation? So without oral health treatment, many patients become stuck with these physical conditions and socioeconomic circumstances. And looking back, the reason I became invested in oral health, because it almost seemed like the magic bullet that would improve people's circumstances dramatically. I remember numerous stories of patients who were working part-time fast food jobs, making $12 to $13 per hour doing odd jobs. But as soon as they got a new smile or even simply getting cavities treated in their front teeth, many of them would not have to utilize their clinic anymore because they got a $24 to $25 per hour customer service job with benefits. And those stories, I think, just underscore that oral health not only plays a huge role in healthcare, but in someone's well-being.
Ian, access to oral health care varies widely across the U.S. and across different populations. And can you share a little bit about why that is?
Well, what we do know is, again, the adult Medicaid dental benefit is really in a patchwork across the United States, in what level of coverage is offered. But the ADA Health Policy Institute has actually done a survey of Medicaid beneficiaries. And more than 45% said they cannot access dental services because they are not covered by their state Medicaid program, or they cannot afford to pay the out of pocket costs for non covered services. I think the other issue that determines access across states is provider administrative burden and reimbursement. We have to remember that dentists do not operate like many physicians that work in settings with a billing or credentialing department. Many dentists practice in small individual or group practices in which the dentists have to often take the burden of doing the credentialing or re-examine claim denials. And frankly, do not have the hours to spend going back and forth on reliable systems for enrollment or credentialing and the denials just to get cents on the dollar. So I can really attest that is an issue among dentists. But one is provider participation is affected by reimbursement again. 80% of dentists say they do not or do not want to participate in Medicaid because of low reimbursement. And so we have to remember that dentists are not asking Medicaid to match their fees, but we needed to make it so that they're not having to essentially have a burdensome workload that's going to burn them out to make up for the losses that occur when servicing Medicaid beneficiaries.
So, Ian, as I understand it, there's a number of factors that can drive up the overall cost of oral health, such as emergency room visits and inadequate preventive care. And can you walk us through some of these costs and how states can alleviate them for individuals as well as for the state coffers?
Yeah, we know that a presence of an adult Medicaid dental benefit provides a tremendous amount of cost savings. We estimate that the adult Medicaid dental benefit, as it stands in 42 states in the District of Columbia today, is providing almost $1.9 billion in cost savings annually. And these cost savings come from the fact that the Medicaid programs with an adult dental benefit spend a lot less when doing prevention, extractions, or restorations, as opposed to patients without a benefit having to go to the emergency room for untreated dental pain or infection. Because emergency room visits on average for a dental condition is $2,380 almost, as opposed to the tens or hundreds of dollars it costs to treat those conditions in a dental office. We also know, too, that the treatment of gum disease is less expensive compared to cardiovascular disease in the long term or keeping babies in the hospital due to premature birth or low birth weight, which can be caused, again, by poor gum hygiene. And so that $1.9 billion in cost savings is huge, but it's not even inclusive of increased economic activity that is generated from the benefit. So the ADA Health Policy Institute released a report called What Happens if the Adult Medicaid Dental Benefit Goes Away? And we actually looked at what happened to states that previously had an extensive or limited adult dental benefit, then took it away due to budgetary constraints. And we found that in the state of California, when this benefit was only gone for 6 years, it led to an estimated loss of nearly 4,500 jobs and over $500 million in economic activity.
Ian, looking at the big picture, what do you think some of the biggest challenges the oral health industry faces in meeting the demand for care, and what sort of solutions are being explored?
In the oral health industry, it has to be inclusive of not only just the solo providers, but state Medicaid programs, the payers or managed care organizations in Medicaid, and dental support organizations. I think one of the challenges we've found among beneficiaries when we talk with them through our research is when you compound lack of knowledge or improvement in their dental benefit or provider availability, transportation issues, and overall care anxiety, patients are not going to be able to access this benefit. So some of the solutions that we believe can make a great impact are making sure that payers who are implementing the EPSDT or the early periodic screening and diagnostic and treatment benefit for child wellness screenings are also reminding parents or following up with them about dental visits and incorporating that, because MCOs often have to make sure that children are getting those within their benefit year. I think another solution is dental support organizations are growing in the United States. They're kind of the Aspen Dentals, Midwest Dentals. And what we're finding is that when these providers are actually, or when these organizations want to participate in Medicaid, the cost of being Medicaid providers is a lot less to them because of economies of scale. They are able to also network different providers in different areas if they don't have availability. And they also do have quality outcome programs incorporated in their organizations that make sure that their patients are getting great health care. So we have learned too that more dentists who are going to work for these dental support organizations are more likely to be Medicaid providers. So I would say those are a couple solutions that we have been exploring in meeting those challenges, as well as talking to our state legislators and strengthening the adult dental benefits as well as the administration of them.
So, Ian, I do a lot of podcasts on a wide range of policy issues, and I think this question is one I ask almost everybody, and that's about workforce. When you think about the challenges in the workforce area in the healthcare field, how does this relate to oral health and to Medicaid in particular? And I think you were just alluding to that a little bit about where we get these providers to be able to bring these services to people who are on Medicaid.
Well, first, I think there are talks of expanding the type of professionals who can enter their oral health workforce in order to solve access issues. And I would personally say that the dividends and return on investment into that area has not shown a significant improvement and have, in some cases, had to be retracted. But rather than add an entirely new category of providers as a nation, I think it's better for us to focus on training more hygienists and assistants, because I can tell you when I was an administrator at these clinics, it was really hard for us to hire those hygienists and assistants that keep our clinics going. Getting dental professionals where they are most needed and helping underserved patients seeking care, being able to connect with dentists for treatment.
Well, Ian, thank you so much. This is, I think, as you've suggested, a not very well understood area, and one I think of great importance for legislators and staff to understand. And I appreciate you explaining it. Thanks very much, and take care.
Thank you.
I'll be right back after this short break with Senator Evan Vickers and Senator Malcolm Augustine.
How can state legislators, staff, and those interested in public policy stay ahead of the curve and keep up with state legislative trends? It's easy. Read NCSL State Legislative News every day and watch NCSL Town Halls. From education to healthcare, elections to taxes, infrastructure to criminal justice, we've got you covered. State Legislatures News is your go-to source for unbiased, comprehensive analysis on the issues that drive change. Each day, you can explore in-depth coverage on crucial policy debates, legislative innovations, and the latest developments in state legislatures. And enjoy profiles of state legislative leaders and prominent legislative staff, as well as discover insights to unique legislative districts across the country. And be sure to watch NCSL Town Halls, your trusted source for legislative insights. These live-streamed events provide timely, energetic, and brisk interviews with experts on key policy issues. Dive into the heartbeat of state politics with timely and insightful articles and interviews that matter. Get access today to State Legislatures News and NCSL Town Halls at ncsl.org/news.
Senator Vickers, Senator Augustine, welcome to the podcast.
Thank you.
Thanks for having us.
So we're talking today about oral health coverage for people who are covered under Medicaid. I talked with Ian Hedges from the American Dental Association about why oral health care is important in the overall healthcare picture. And with you, Senators, I wanted to discuss what your experience has been in the legislature. And Senator Vickers, let me start with you. In 2024, Utah passed legislation requiring your Department of Health and Human Services to seek a waiver from the Centers for Medicare and Medicaid Services to expand dental services to Medicaid-eligible adults 21 and over who previously were ineligible. And I wonder if you can talk about how that legislation came about in Utah and why it was an important thing for you to see passed.
Yeah, well, thank you. Yeah, it's been a critical element in providing coverage for Medicaid patients and especially in the dental area. We started out with a program, with a managed care program to deal with children with pediatrics and with pregnant mothers. Then we have this traditional Medicaid program primarily for dental patients. We saw a consistent habit coming out in that practitioners continue to refuse to take Medicaid patients just because of the low reimbursement, those types of things. The dental school at the University of Utah, previous to that, we did not have a dental school, but they're celebrating their 10th anniversary now. Once they got involved, they started taking a role that they tried to provide better coverage and see if they couldn't build up a network of providers. So they started out small. They used their endowment that they originally had with the dental school to provide coverage for the blind and disabled and those who were suffering under substance abuse. They used the endowment for the match, and then any work that they did by their students, they were able to get reimbursement through Medicaid, and so they could kind of cover the match with that. And then they started building a provider network whereby they could provide a higher reimbursement. So obviously they had to get a waiver, through Medicaid to do that, and they were able to provide a higher reimbursement to those patients. They expanded that a couple of years later to include elderly. And then, as you mentioned, in 24, we were able to go to all adults that are not previously covered under another program. And what the dental school has been able to do is they've been able to go into the provider networks throughout the state and build up a network where they will accept, the Medicaid patients. They'll get a higher reimbursement. It really doesn't cost the state anything because they're using their endowment and then whatever reimbursement they're getting at the school to cover the match. So it's been really a good positive thing. We're now up over 400 providers that are participating in the program, and it's been a real positive thing. Like all other primary care, if you can take care of a patient at the lower level entry challenges, then you can prevent it from escalating into something that turns into very serious and very expensive for the state later on. So it's been a good program.
Yeah, I've certainly heard that these things, the delayed oral health care, can often lead to more serious healthcare problems. And Senator Augustine, let me ask you about the tragic death of 12-year-old DeMonte Driver back in 2007. And I know this sparked some action in Maryland to increase oral health services. I wonder if you can share why that was such a seminal moment and also why that was an important impetus for this action in Maryland.
No, thank you so much, Ed. I think that anytime we lose the life of a child, it really touches us in an emotional way, particularly if that loss of life was preventable. And this was an absolutely preventable loss of life that with just basic dental care, we would have been able to save young Diamante's life. And that touched the hearts of the people of our state and really moved us in a direction to really improve and expand dental coverage for children. And that really was an impetus for us to do that in order to really save some lives and improve dental care for young people at that time.
And Senator, let me stick with you for a minute. So what has gone on in Maryland in terms of trying to address the oral health needs?
Sure. Now, while we address the oral health needs of our children after the tragic loss of Diamante's life, we're behind, quite frankly, as it related to adult Medicaid recipients in our state, as one of the few states that did not offer a comprehensive dental care. And so we realized that this was actually costing us a significant amount of money. A significant number of our emergency room visits were patients who were there for dental services. And so in 2022, we put forward legislation to create a comprehensive dental benefit for Maryland adult Medicaid patients, and we're able to pass that. Now, there is a significant investment by our state in order to do that, but we felt like it made sense to do so as dental is an indicator of other conditions. And so we felt that it would help us as a preventive measure, in addition to a matter of dignity for our adult Medicaid patients.
Senator Vickers, you alluded to this before, but I think probably every public policy podcast I do, the issue of workforce comes up. And you talked about working with the university. I wonder what advice you would give your colleagues in other states, specifically about that workforce issue. It sounds like it's worked out well there in Utah. How would you just suggest approaching the higher education facilities, the dental schools, that kind of thing, and how that works with them, why it works out for them?
It's been a unique challenge. As I mentioned, we have many dentists that would refuse to take any kind of Medicaid patients or any new Medicaid patients. Certainly was limiting the accessibility for patients throughout, especially into the rural areas. So we were finding it was becoming a real challenge for us in Utah, and I think each state can be creative and be new, and they can look at it their own individual assets and challenges that they might have. With us, the dental school worked with the dental association, and then with Medicaid to kind of create kind of a triangle or trifecta kind of approach to reach out to providers and find out what procedures needed to be enhanced, that the reimbursement needed to be enhanced in order to rise it to a level that they could make a profit on it. They worked through that study as we slowly built this up. As I mentioned, we started out with blind and disabled, and then substance abuse, and then elderly. Now we're just ready. Now we just received the full go-ahead on the waiver, so we can start into the whole complete adult population, at least if there are those that aren't covered in another method. And so the dental school and the dental association have taken the lead on that, reaching out individually, one by one, to providers across the state, working with them. We also added a little bit of enhancement. With the dental school, the state provides we specifically provided 3 scholarships for rural students. And one of the stipulations is that once they, graduate, and then they start into practice, they have to be willing to accept Medicaid. We've kind of worked around this from a number of different angles, but the bottom line is you've got to get the reimbursement to the providers up to a level that they can afford to take the patient. Then if you can do that and then get that network going, then obviously you've got access for the patient. And it's challenging. It's challenging for any patient, but especially a lower income patient, if they've got to drive a long ways or just, they might just get frustrated and say, oh, the heck with it, and then that's when it leads to some real serious things. They end up in an emergency room, and that leads to all a significant increase in cost, but also a significant increase in severity of their mental and medical health care. So.
Yeah, this issue of travel and the cost of it, just the difficulty for it, especially for people with low incomes, I hear that a lot around healthcare issues. Senator Vickers, let me just stick with you as we wind up here, and I'd like to ask both of you, just generally, what would your advice be to your colleagues around the country, just in trying to address this problem? It sounds like Utah has taken kind of a tiered approach here. Any other suggestions you'd have for other legislators around the country as they look at this issue?
Sure. I think the first thing is to evaluate, work with whoever your resources are. For us, it was Medicaid, it was the dental association, it was the dental school. We started doing some evaluations. and see where we could, be beneficial. And then get creative. States are kind of the incubators of creativity, and each state's going to be a little different. What works in Utah may or may not work in another state. And we're a little smaller. We don't have as many dental schools, but the same token, maybe that model works. But first evaluate, and then look at and start asking some questions. Why aren't providers taking Medicaid patients? That's what we did. We kind of went through the process and found there's a lot had to do with reimbursement. Okay, and then once you identify the challenges, then start looking for some creative solutions. And that's what's happened with us. I mentioned that we have a managed care model for pediatrics and pregnant mothers. We've actually recently done an evaluation on that, and it appears now that if we can move that population into this provider group that we're working through the dental school with, we can save the state about $20 million a year. So it's kind of an ongoing evaluation, but it started with us. It started small, and now it's built up. So I would say, evaluate, identify, and then get creative.
Senator Augustine, I think Senator Vickers makes a great point, which is that, and certainly has been my experience, that if you know one state, you know one state. Everybody's situation is different. So how about from the Maryland perspective? What would you tell your colleagues around the country? What kind of lessons have you learned?
I would say that it's important, as the senator said, to look within and to understand the values of your state and what you prioritize and what you find to be important, and follow that. And that is a place that we start from. We are trying to identify the best and highest use of our resources. And I would suggest that other states do the same. They find the things that matter to them the most. And if they believe that the care of the folks and the benefits of oral health and the dignity of a smile, which can contribute, again, you talk about workforce, a person is obviously going to feel far better about going to work if they're comfortable opening their mouth and being able to really contribute. If you think that those things are important, you do everything you can to maximize the resources that you have in your state in this regard. And that would be my suggestion. That's what we've done here in Maryland. It's why we expanded this. We find it to be an excellent investment, and that would be my advice.
Well, I've certainly heard this issue that good oral health helps promote personal dignity, as well as helping people, giving them a leg up when they go to apply for a job. And I want to thank both of you gentlemen so much. I think this is a somewhat overlooked area of healthcare, and I think it's an important one to bring some attention to. So thanks, both of you, and take care.
Thank you.
Thank you.
I've been talking with Ian Hedges from the American Dental Association, Senator Evan Vickers of Utah, and Senator Malcolm Augustine of Maryland about the challenges and opportunities for providing adult oral health care under Medicaid. Thanks for listening. You can check out all the podcasts from the National Conference of State Legislatures by searching for NCSL Podcasts wherever you get your podcasts. This podcast, Our American States, dives into some of the most challenging public policy issues facing legislators. On Across the Aisle, host Kelly Griffin tells stories of bipartisanship. Also check out our special series, Building Democracy, on the history of legislatures.